Okay, it's 4.
All right, well, I just want to thank everybody for coming to the NEP seminar series for this spring semester. The schedule was out, and I think everybody can see we've got 13 weeks of virtual seminars. So this entire spring semester will be via Zoom. But I think there's some really great speakers this week or this semester. I'm so excited for the whole schedule. A couple unique features this semester. There are 3 weeks that are sponsored by our graduate students. So the speakers were invited entirely by the students, and sessions will be moderated by the students. I'm so excited that today we have Dr. Martins as our first speaker for the seminar, and Dr. Engel will introduce her as well as help facilitate the question and answer. We're all really good at Zoom seminars by now, I think, but throughout the seminar, feel free to type in, excuse me, any questions into the chat, and Dr. Engel will make sure Dr. Martins gets your questions. During the Q&A, you're also welcome to raise your hand, and I'll help keep an eye out. So if anybody wants to ask their question directly to Dr. Martins, that will be possible too. So thank you, everybody, for attending, and thank you, Dr. Martins. This is a great way to start the semester.
Alrighty. Thank you, Jackie, and welcome to everyone to today's seminar series. It's my pleasure to introduce our very first speaker, Dr. Catia Martins. So Dr. Martins has a first degree in nutrition and dietetics from Porto University in Portugal. She also has a master's in clinical nutrition from Roehampton University and a PhD from Surrey University, both in the UK. She has been working at the Norwegian University of Science and Technology since 2008, where she was promoted to full professor in obesity and metabolism in 2019. She is the leader of the Unit for Clinical Medicine and Metabolic Diseases within her Department of Clinical and Molecular Medicine. Dr. Martins is also an adjunct associate professor at the University of Queensland in Australia as of August 2020, and was a visiting scientist at University of Alabama, Birmingham's Nutritional Science Department from 2019 to 2020. Dr. Martins' research focuses on the impact of weight loss on appetite and energy metabolism, and also predictors of relapse in obesity management. Her group has challenged the old paradigm, which states that weight regain is driven by compensatory responses on both sides of the energy balance equation. Her research has in fact shown that the increased drive to eat and reduced energy expenditure that is seen in the reduced obese state are actually a normalization towards a lower body weight and not drivers of relapse. Today, Dr. Martins' talk will address the question, does increased appetite and reduced energy expenditure really drive weight regain? I'm sure we are all excited to find out the answer to this question. So without taking too much time, I'm going to open the floor to Dr. Martin. So.
Thank you very much for the nice presentation, Catherine, and also thank you very much for the invitation to present my work. Oops. These are my disclosures, and this is a short outline of my presentation. So I will first discuss the changes in appetite that occur with weight loss, and then their potential predictive role or not in driving relapse in obesity treatment, so weight regain. I will then move into energy expenditure and show you what we know per today regarding the impact of weight loss and on energy expenditure, and then discuss their predictive role or not in relapse. And at the end, I will propose a new theory, the normalization theory, to explain the changes in appetite and energy expenditure that occur with weight loss. Now, we all know that the main challenge in obesity treatment is weight regain. And this happens regardless of the intervention that is used to induce weight loss. So regardless of it being diet, exercise, a combination, or to a lower extent, bariatric surgery, the long-term outcomes are weight regain. And we, per today, do not know yet what are the main mechanisms that lead to weight regain in the long term. there are two main views. One is that individuals with obesity lack willpower, and therefore that there is poor compliance to diet and exercise regimes. So basically that reduced obese individuals sooner or later will return to their bad habits of sedentary lifestyle and overeating. It's what we know as self-regulatory failure. So that restraint inevitably lead to loss of restraint or disinhibition. The other view is that the body fights back when weight loss occurs and tries to bring body weight back to its original state. And that is known as the compensatory theory. So basically that when an individual loses weight, there is an increase in the drive to eat despite a significant reduction in total energy expenditure. And it is on this side here of this slide that I'm going to focus during the next 45 minutes or so. Now, particularly over the last decade, there has been a large number of reviews suggesting that weight regain is driven by compensatory responses on both sides of the energy balance equation, what is known as the compensatory theory. So just to put it very simply, what this theory suggests is that weight loss leads to an increase in the secretion of the hunger hormone ghrelin, as well as an increase in subjective feelings of hunger, leads to a significant reduction in the secretion of satiety peptides after a meal, and a significant reduction in feelings of fullness in the postprandial state. Also, that weight loss would lead to metabolic adaptation. Metabolic adaptation means a significant reduction in energy expenditure below predicted value, so below what would be expected for the lower fat mass and fat-free mass. And that then these adaptations would then lead to positive energy balance, which if sustained in the long term, would drive weight regain. So what I'm going to talk during this presentation is first, do these adaptations really occur? And second, if they occur, are they really predictive of relapse in the long term? The landmark paper when it comes to changes in appetite induced by weight loss is this paper here that was published in 2011 in the New England Journal of Medicine by Sumitran and colleagues from Australia. What they did was that they recruited 50 individuals with overweight or obesity. They put them through 8 weeks of a very low energy diet, followed by 2 weeks of refeeding and weight stabilization and a 1-year weight maintenance program. And as you can see here, there was partial weight regain, approximately 50% weight regain at 1-year follow-up. And then they measured body weight and composition and subjective feelings of appetite using validated visual log scales, and took blood samples both in fasting and after a standardized meal to look at the secretion of appetite-related hormones. And they did that at baseline, at week 10, and at 1-year follow-up. And here is what they found regarding changes in appetite. And be aware that baseline, so pre-weight loss, is the black line. After weight loss is the blue line, and at 1-year follow-up is the red line. So what they found was that the secretion of the hunger hormone ghrelin was significantly increased with weight loss. And this increase was still there at 1-year follow-up despite a 50% weight regain. And they found the opposite pattern for the satiety hormones PYY and CCK. So their secretion was reduced after weight loss, and that reduction was still seen at 1-year follow-up. Similar pattern when it came to subjective feelings of hunger and desire to eat. There was an increase both in the fasting state and in the postprandial state with weight loss that was still there at 1-year follow-up. And so the authors concluded that we need to counteract these changes in appetite if we want to succeed in the long term regarding weight loss maintenance. Now, I have to tell you that not all the evidence points to the same direction. So this study that I want to show you now comes from the group of Professor Jens Holst from Copenhagen University, where they did a similar intervention, this time in 20 individuals with obesity. that undergone an 8-week very low energy diet and were then followed for 1 year. And again, they measured the secretion of appetite-related hormones at baseline, after weight loss, and at 1 year follow-up. And what they found was significantly different from what I showed you from the Sumitran paper. So if we look into the secretion of satiety peptides, GLP-1 and PYY, what they found was that there was an increase in the secretion of these hormones in the postprandial phase after weight loss and at 1 year follow-up. This was total GLP-1, and the same for PYY 336. So an increase in the postprandial phase after weight loss that was still there at 1 year follow-up. For ghrelin, they reported the same as Sumitran, so a significant increase in weight loss that was still there at 1 year follow-up. And in fact, these authors concluded that it was this increased secretion of satiety peptides that contributed to the success of the intervention in the long term. Now, my research group has also done a similar study, but much larger. So we recruited 100 men and women with obesity. We put them through an 8-week very low energy diet, followed by 4 weeks of refeeding and a 1 year maintenance program. And we were able to induce a 17% weight loss and to maintain that weight loss at 1 year follow-up, which is pretty unique. And again, we measured body weight and composition and several markers of appetite at baseline, after weight loss, and at 1 year follow-up. This here is subjective feelings of appetite in the fasting state. Again, we have a significant increase in hunger after weight loss that is still there at 1 year follow-up. Here we have the postprandial profile of subjective feelings of appetite. We found a significant increase in postprandial hunger that then went back to baseline at 1 year follow-up. And surprisingly, we found a significant increase in postprandial fullness with weight loss sustained at 1 year follow-up, opposite what is generally accepted to occur after weight loss. Regarding the secretion of appetite-related hormones, here we have fasting levels. We found a significant increase in acylated or active ghrelin with weight loss that was still there at 1 year follow-up. A similar pattern for postprandial plasma concentrations of active ghrelin. We found no changes in the secretion of active GLP-1, that is a satiety hormone. For total PYY, that is another satiety hormone, we found no changes with weight loss, but a reduction at 1 year. And for cholecystokinin, that is another satiety hormone, there was a reduction with weight loss and an increase at 1 year follow-up. So these 3 studies show a common impact of weight loss on ghrelin. So there's no doubt that weight loss leads to an increase in in ghrelin and hunger. But when it comes to the impact of weight loss on satiety peptides, the results are divergent. And so to try to come up to a conclusion in this field, we decided to perform a systematic review and meta-analysis that we hope to submit very soon to investigate the impact of diet-induced weight loss on appetite. Our criteria were that the studies had to induce significant weight loss, defined as a cutoff of 2 kilos. They could include exercise, but exercise could not be the only intervention. We did not want studies that included pharmacotherapy, and appetite could be assessed either subjectively with Vision log scales, that is considered the golden standard, or by measuring the plasma concentration of appetite-related hormones. And the measurements had to be done outside of ketosis because it is well known that ketosis modulates appetite. And so I want to show you our results here. This is for hunger feelings in fasting. And as you can see here, the overall effect is towards an increase in hunger in fasting after weight loss. The same for total ghrelin and active ghrelin in fasting. But, and surprisingly, weight loss is also associated with a significant increase in fullness after a meal and a significant reduction in prospective food consumption after a meal. When we looked into the release of satiety peptides, we were very careful in not mixing data from studies that have measured the same hormone but different fractions. That is not a problem for cholecystokinin, where we found that weight loss was associated with a significant reduction in the release of this hormone in the postprandial state, but it is an issue both with PYY and GLP-1. And so we can either measure total PYY, or you can measure PYY free 36, that is seen as the active component of the hormone that has a role in appetite control. When we looked into total PYY, we saw no effect of weight loss on the release of this hormone in the postprandial state. And for GLP-1, we can measure either active GLP-1 or total GLP-1. For active GLP-1, we saw no effect, as we can see here. For total GLP-1, we did not have enough data to perform a meta-analysis, but the 4 studies available, 3 show an increase and 1 show no change. And for PYY 336, the only available study, that is the Epsom study that I have showed you from Copenhagen, shows an increase. Now, from a physiological point of view, the best fractions to use are total GLP-1 and PYY 336 in terms of their use as a predictor of appetite responses. So overall, what we see is that weight loss is associated with an increase in ghrelin and hunger, but also an increase in postprandial fullness. And when it comes to the release of the satiety hormones, the results are mixed and show a reduction in CCK, no impact on total PYY and active GLP-1, and it seems to have a positive impact on the release of total GLP-1 and PYY 336. So then the next question is, okay, but do the changes in appetite, the increase in ghrelin and hunger, well, are they predictive of weight regain in the long term? If we go back to the reviews that are available in this field and that suggest that the increased appetite and the reduction in energy expenditure are predictors of weight regain, only one of them raises a very important issue. And that issue is that the evidence demonstrating a causal relationship between an increase in appetite or reduction in energy expenditure and weight regain is non-existent. And I will show you what we know for today. If we go back to what is considered the landmark paper regarding the impact of weight loss on appetite, that is a study from Sumitra, where the authors have concluded that we need to prevent these changes in appetite if we want to succeed in the long term. If we look at their supplementary material, we can see that the authors clearly state they could not find any correlation between weight regain and fasting or postprandial values for either hormones or VAS for appetite, or changes. So the changes in appetite that occur with weight loss were not predictive of weight regain. So I wonder how the authors were able to come up with that conclusion. There is also a review from Strohacker that has concluded that changes in leptin, ghrelin, or insulin that occur with weight loss are not predictive of weight regain. And finally, my group has also tried to answer this question. And what we did was that we had data from a group of obese individuals that had lost weight with a very low energy diet over 8 weeks, followed by a 4-week refeeding and weight stabilization period, and that then was followed up for 1 year. And we measured body weight and body composition, subjective feelings of appetite using visual log scales, plasma concentration of appetite-related hormones in fasting and after a standardized meal, and finally, energy expenditure at rest and during exercise using a cycling protocol at 3 different levels of resistance. This group of 36 individuals lost approximately 20 kilos or 17% weight loss and was able to maintain that weight loss at 1 year follow-up. And let's see what happens regarding appetite and energy expenditure in this group. Well, as expected, fasting hunger increased with weight loss. Both basal or fasting and area under the curve for active ghrelin also increased with weight loss. And energy expenditure at rest and also during exercise. So this is net exercise-induced energy expenditure at 10, 25, and 50 watts. So both at 10 and 50 watts, we saw a reduction in energy expenditure. And regarding other subjective appetite sensations and other hormones, the changes were not significant. In some of them, potentially, there were issues with power. But so our question was, do these changes in appetite and energy expenditure that occur with weight loss, are they predictive of relapse at 1 year follow-up? And so in this first slide, what we have here is the association between changes in ghrelin. In the top scatter plot, we have fasting ghrelin, and in the bottom scatter plot, we have area under the curve for ghrelin. And then on the y-axis, we have weight regain at 1 year. So it would be expected that the larger the increase in ghrelin with weight loss, potentially the more would be the weight regain. Now, what we found for both fasting and postprandial ghrelin was a tendency in the opposite direction. So as you can see here, the larger the increase in ghrelin with weight loss, the less was the weight regain, or the participants even lost further weight at 1 year follow-up. And these happen both for fasting ghrelin and for area under the curve of ghrelin. We then looked at a potential association between changes in hunger with weight loss and weight regain. We found no association. We did the same for resting metabolic rate, for exercise-induced energy expenditure, for the other subjective feelings of appetite, and for the other appetite-related hormones, and we could not find any significant association. So the main findings of this study was, first, that there are no associations between changes in appetite or energy expenditure with weight loss and weight regain at 1 year follow-up. And in fact, that there is a tendency for better weight loss maintenance in those experiencing the large increase in ghrelin secretion. And you're probably asking yourselves, how can that be? Well, you need to remember that ghrelin is an inverse adiposity signal. That means that as BMI and fat mass increase, ghrelin concentration decreases. And so those individuals that lost more weight and more fat with the intervention also had a larger increase in ghrelin. And in this study, those that lost the more weight at the beginning were also those that were better able to maintain that weight loss in the long term, which is a pretty common finding in weight loss interventions. And so we believe that the increased ghrelin secretion or concentration reflects, in fact, the lower body weight and fat mass of those achieving a better weight loss maintenance. So to give you a summary regarding changes in appetite with weight loss leads to a sustained increase in ghrelin secretion and hunger feelings, but also increased postprandial fullness. The impact of weight loss on the postprandial release of satiety peptides, so GLP-1, PYY, CCK, remains controversial and is likely to be modulated by the specific hormonal fraction that is measured. And more importantly, the increase in the drive to eat, so ghrelin secretion and hunger feelings that occurs with weight loss, is not predictive of relapse. Okay, so I'm now going to move to metabolic adaptation. So again, metabolic adaptation is a reduction in energy expenditure below predicted values. So even if we account the reduction in fat mass and fat-free mass, then would still be, if we measure resting metabolic rate or total energy expenditure, would still be below that value. Now, when or before that, the existence and clinical relevance of metabolic adaptation has been one of the most controversial issues in both nutrition and obesity research. And so when I started thinking about this topic, I decided to do a literature search and see, what we know per today. And I was quite surprised by finding some interesting trends. What I found was that the majority of the cross-sectional studies that compare weight-stable reduced obese individuals with BMI matched controls tend to show no evidence of metabolic adaptation. But longitudinal studies that follow individuals over time in their weight loss journey tend to find metabolic adaptation. Also, I could not find one single study that showed that metabolic adaptation was associated with more weight regain in the long term. And so we came up with some new hypotheses that we wanted to test. The first one was that differences among studies derive from inconsistencies related with the energy balance status of the participants when the measurements are taken. And the second one was that metabolic adaptation does not predict relapse. And so in order to test these two hypotheses, I used data from studies done in 2 different continents. The first study that I'm going to show you was with data from USA during my sabbatical period at UAB in Birmingham, Alabama. And the second study that I'm going to show you is with data from Norway. So this is the first study that I want to show you in a population of 171 overweight women, approximately half white, half black, that were enrolled in a weight loss program that aimed to achieve a BMI below 25. And that were then followed for 2 years. And what it is rather unique about this study was that body weight and body composition and resting metabolic rate were measured after 4 weeks of weight stabilization at baseline, after weight loss, at 1 and 2 years follow-up. And this weight stabilization period was done under highly controlled conditions. In the first 2 weeks, the participants were weighed 3 times per week while they're consuming their own food. And on the last 2 weeks, they were weighted 5 times per week with food provided by the research center. And all the testing was done in the follicular phase of the menstrual cycle and during a 4-day inpatient stay to ensure both physical activity and diet standardization. And body weight variation during these last 2 weeks was plus minus 1 kilo. So regarding, did we find metabolic adaptation or not? So we defined metabolic adaptation as a significant difference in measured versus predicted resting metabolic rate. And the predicted resting metabolic rate was achieved by doing regression analysis using our own data at baseline. And so as you can see here, after a 12 kilo or 16% weight loss, our participants experienced a significant metabolic adaptation, but of minor magnitude. So we are talking about approximately 50 kilocalories per day. And no differences between races, as you can see here. Then what we did is that we looked into those individuals that had data at all time points. It was 46 ladies that had experienced on average a 50% weight regain at 1 year and an 83% weight regain at 2 years follow-up. And again, we looked into metabolic adaptation. And as you can see here, there was metabolic adaptation after weight loss, on average 40 kilocalories per day, but that disappeared both at 1 and 2 years follow-up. Now remember that at 1 year, they had a body weight that was still significantly lower than baseline, approximately 6 kilos on average, and they did not present with metabolic adaptation. So the next question was then, okay, but does metabolic adaptation predicts weight regain? And that is what we looked at in these 2 scatter plots here. So here we have metabolic adaptation in the y-axis, and here we have weight regain at 1 year and at 2 years follow-up. And so we would expect that the larger the metabolic adaptation, the more was the weight regain. But what we found was a tendency towards the opposite pattern, particularly in African Americans. So as you can see here, the larger the metabolic adaptation, that appears as negative values here for the difference between resting metabolic rate measured and predicted, the less was the weight regain, or participants even lost further weight. And that happened both for 1 year and for 2 years, as you can see here. And we believe that the reason for that is that metabolic adaptation is a reflection of the amount of weight lost. And because those that lost more weight at the beginning also were able to maintain it better in the long term, that reflects the initial response. And we have evidence for that. So as you can see here, this is weight loss and this is fat mass loss. The larger the weight and the fat mass loss, the larger was the metabolic adaptation. Okay, so let's now go to study number 2, done in Norway, in a different population. So now we have men and women with obesity that enrolled in a 1,000 kilocalorie per day diet for 8 weeks, followed by 4 weeks of weight stabilization and a 9-month weight maintenance period. And again, we measured body weight and body composition and resting metabolic rate at the 3 time points. So there was an average 14 kilo or 13% weight loss at week 9 that was maintained at week 13. Now look at the results regarding metabolic adaptation. We had a metabolic adaptation of approximately 90 kilocalories per day when the measurements were done immediately after weight loss. But when we measured these patients again after 4 weeks with exactly the same weight, metabolic adaptation was less than half. Was only 40 kilocalories per day. And then we did another subgroup analysis in 45 individuals that had also data at 1 year follow-up, and they had regained approximately 30% of their body weight, and metabolic adaptation had disappeared. When we asked the question, does metabolic adaptation immediately after weight loss or after 4 weeks of refeeding and weight stabilization predict weight regain? The answer was no, it does not. So does metabolic adaptation exist or is an illusion? As I have shown you, under conditions of weight stability, and study 1 and study 2 gave very similar results, we should expect a metabolic adaptation of around 40 to 50 kilocalories per day. However, metabolic adaptation is likely to be overestimated in these 2 studies. Why? Well, because even though our participants were weight stable, they were most likely in negative energy balance. And the reason for that is that we have used ketogenic diets to induce weight loss. In the first study, we used the 800 kilocalorie per day diet. And on the second study, we used the 1,000 kilocalorie per day diet. And we have measured beta-hydroxybutyrate, that is a ketone body, and participants were ketotic. And so when we start refeeding participants, what happens is that they start building up their glycogen stores that are approximately half a kilo. And 1 gram of glycogen is stored with 4 grams of water. And therefore, we should expect an increase in body weight due to increased body water content of approximately 1 to 2 kilos when individuals come out of ketosis. And that explains why our participants, despite being weight stable, were most likely in negative energy balance. Why is this relevant? Well, when we went back to study 2, I told you that participants maintained their body weight between week 9 and, week 8 and week 12 at group level. But of course, there was inter-individual variation. Some lost weight, some gained weight. And so when we picked up the subgroup of individuals that had gained weight and therefore was more likely to be, or if you want, less likely to be in negative energy balance, 33 individuals here, what we saw was that at week 13, there was no metabolic adaptation. So to conclude this part about metabolic adaptation following weight loss, metabolic adaptation at the level of resting metabolic rate is dependent on the energy balance status of the participants. It's minimal but significant when measurements are taken under conditions of weight stability, but is likely an illusion when participants are in energy balance. And more importantly, is not correlated with weight regain in the long term. So if the increase in appetite and the reduction in energy expenditure are not a compensatory response that drives relapse, then what are they? Let me give you an example for ghrelin. As I told you, ghrelin is an inverse adiposity signal. So we should expect its secretion to reduce as BMI and fat mass increases. We know that obese individuals have significantly lower plasma concentration of ghrelin compared with the normal weight. And we also know that when individuals lose weight, the plasma concentration of ghrelin increases. The question is, does it increase to the same level that would be expected in a BMI matched control or not? We also asked the same question and decided to design a study to answer it. And so our aim was really to compare appetite markers in reduced obese individuals with a non-obese control group that was matched for body composition. That is what we have here. So we had 34 obese individuals that lost weight through a very low energy diet, followed by weight stabilization, that then came at week 13 and came back at 1 year, and they maintained their weight loss. And then we were able to recruit a control group that was non-obese, but very important, was matched for fat mass and fat-free mass. Despite being younger and having a higher weight and a higher BMI, they had a similar body composition. And so when we compared hunger, desire to eat, prospective food consumption, and the plasma concentration of active ghrelin in fasting between reduced obese at 1 year follow-up and controls, we found no difference. Here is postprandial subjective feelings of appetite. Again, there is an increase in hunger at week 14, at 1 year, but no differences between reduced obese and the controls that appear as the blue column. Fullness increased with weight loss, but again, to levels no different than those seen in controls. This is the secretion of appetite hormones after a meal. Ghrelin increased, but to levels no different seen than those seen in controls. When it comes to the release of satiety hormones for active GLP-1, total PYY, and cholecystokinin, plasma concentrations in obese and reduced obese were always significantly lower than in controls. PYY 336, the reduced obese at 1 year were significantly lower than the controls, but not at week 13. And for total GLP-1, reduced obese at week 13 had significantly lower secretion of total GLP-1 compared with controls, but not at 1 year follow-up. So just to summarize, weight-reduced individuals that were weight stable, so at 1 year follow-up, experienced increased ghrelin secretion, but to levels no different than those seen in controls. Increase in hunger in fasting, but again to levels no different than those seen in controls. Increase in postprandial fullness, but to levels no different than those seen in controls. And finally, there were no significant changes in the secretion of satiety peptides overall, but the levels are lower compared with controls. So I know that I only have 5 minutes, but I think I only have more 3 slides. So here I want to contrast what the theory that was accepted before, that is the compensation theory, with the new theory that we are proposing, that is the normalization theory. And we published this in a narrative review in the American Journal of Clinical Nutrition just a couple of months ago. So the compensation theory proposes that reduced obese individuals are significantly different from non-obese BMI matched controls. So basically, that reduced obese individuals experience metabolic adaptation, so a reduction in resting and non-resting energy expenditure below predicted values, increase in exercise efficiency, and also that they experience an increased drive to eat, increase in hunger feelings, reduction in fullness feelings after a meal, increase in ghrelin secretion, and reduction in the postprandial secretion of satiety peptides. And that these adaptations lead to weight regain. What we propose in our normalization theory is that reduced obese individuals and non-obese BMI matched controls are similar when it comes to energy expenditure and appetite. So we propose that reduced obese individuals do not have metabolic adaptation if the measurements are taken under conditions of energy balance. And in fact, that they experience an improved homeostatic appetite control compared with the obese state. Yes, there is an increase in hunger feelings in weight loss, but also there is an increase in feelings of fullness after a meal. There is an increase in ghrelin secretion, yes, but there also seems to be an increase in postprandial secretion of satiety peptides, such as total GLP-1 and PYY346. And that these adaptations at the level of appetite and energy expenditure are not drivers of weight regain. I would like to thank my research team in Norway, fellow colleagues, postdocs, PhDs, master students, statisticians, and lab technicians, and also my international collaborators at University of Copenhagen, at Queensland University of Technology in Brisbane, Australia, and of course at UAB in Birmingham, Alabama. And the main funding body for the research that I have shown you today here, the Liaison Committee for Education, Research and Innovation in Central Norway, and the Norwegian University of Science and Technology. Okay, thank you very much.
Thank you very much, Dr. Martens. We'll now open the floor for questions. There are a few questions in the chat. I'm going to read. Do you see the questions? Do you want me to read them for you?
No. The first question asks if the differences in satiety hormone responses between the first study and my study were due to the test meal composition. Well, the different studies tend to use different test meals, there is no doubt. But what is the most important factor here is that the same test meal is used over time. So the same test meal is used before weight loss, after weight loss, and for example, at 1 year follow-up. But if you look into the Sumitran study, the Jepsen study, and my study, that were the ones that I had in the initial slides, they all used approximately a meal with approximately 500 to 600 kilocalories, and it was a mixed meal. So I think that the differences between studies are mainly explained by the hormonal fractions that were measured. And so we should expect different results if we measure, for example, total GLP-1 and active GLP-1, or if we measure total PYY or PYY346. There are, of course, methodological challenges. For example, PYY346 circulates in very low amounts. And so sometimes when we do the analysis, we get participants with values below the detection limit, and that is a challenge. But measuring PYY346 seems to be a better measure of appetite and food intake compared with total PYY. While if we talk about GLP-1, it seems that total GLP-1 is a better marker compared with active GLP-1. So I hope I have answered that question. I don't know if Elizabeth Parks want to add anything else. No. Then
I was wondering if the choice of the meal you choose, one meal, which an oral glucose tolerance test isn't a meal, but some people call it a meal, if one kind of test would be impacted by the intervention and another test wouldn't. If a meal has protein, is it much less likely than to show an adaptation versus oral glucose tolerance test? Pretty sophisticated question. I know that we don't know the answer, but
the majority, I think all, but I would say the majority of the studies that have looked into the impact of weight loss on appetite have used mixed meals. So they have protein and fat and carbohydrates. Of course, the proportion may be slightly different, but they are mixed meals. The next question is the weight that is lost and the weight that is regained occurred in the same places of the same composition? I have not looked into that, so I don't know the exact question. I don't know. The next one is, when looking at energy expenditure, is it corrected for muscle mass? Would that impact your results, particularly obese individuals who lose lean body mass? Yes, so in our regression model, we predicted resting metabolic rate using both fat mass and fat-free mass changes. So that has been accounted for. The next one says, bravo for completing these difficult studies. Thank you. I had a team on my back. I didn't do this alone. To generate data, you have to have subjects to go through an intensive weight loss program before you can then follow them over months to find out who regains weight. How successful are weight lifting programs to mitigate the reduction in energy expenditure during weight loss? From my understanding, there are several studies that show that resistance training or lifting reduces the loss of lean tissue during weight loss interventions, and therefore also reduces or prevents or minimizes is potentially the best word, minimizes the reduction in resting metabolic rate to occur with weight loss. So I think resistance training together with cardiovascular exercise should always be part of integrated lifestyle interventions for weight loss. That's my opinion. The last one is, in your opinion, what are the greatest predictors of or drivers of relapse? Well, that question, I don't know the answer yet. I have several hypotheses, but I think that it is important first that we accept that the compensatory theory is not the answer, and so that we are able to move on. Now, with that said, I'm not saying that physiology does not have a role in weight regain. There are other aspects of physiology that may be involved, and even other aspects of appetite. What I have talked about during this presentation was the homeostatic appetite control system. So when appetite is driven by a lack of nutrients, either acutely or in the long term. Then we also have a parallel system that is the hedonic appetite control system that basically is related with food reward and pleasure. And there are some studies that suggest that weight loss also leads to changes in the hedonic appetite system. And so it may be that changes in liking and wanting of food in high and low in fat and sugar may also modulate long-term outcomes when it comes to weight loss interventions.
Any other questions? You can speak up, put yourself off mute and speak up.
I was going to wait for the students while they're formulating a question. I wondered if you could talk about strategies for the patients. We have patients who begin to lose weight very quickly. They're doing really well. They understand the dietary changes we're asking them to make, and they're the ones that we should really spend less time on. Have you got some ideas for practical strategies for the patients who really are losing weight very slowly at the beginning, and that's a real predictor of poor outcomes?
Your question is very interesting. We have also published a study last year clearly showing that the faster and the larger the initial weight loss, the better are the long-term outcomes. So as you say, if we are able to have strategies to implement in those that are doing less well right at the beginning, that is going to help in the long term. What to do, I'm unsure, because I don't think we know per today if the resistance to weight loss is driven by physiology or by behavioral aspects, or potentially I believe they are driven by a combination. We have two other articles under review at the moment where we show that metabolic adaptation may be relevant during the weight loss phase. So even though I have shown that metabolic adaptation does not modulate weight regain in the long term, we have shown that during a negative energy balance, those that have a larger metabolic adaptation lose less weight and fat mass in response to the same intervention. And in another study, that it took longer for them to reach their weight loss goals. And so I think when we have an individual that seems to be compliant with an intervention, and of course this is always difficult to assess in clinical practice, we may think, well, maybe this individual is someone that has a very large metabolic adaptation. And of course the question would then be, so what can we do? From the study that I have shown you in Norway, I have shown you that if you stop the dietary intervention, if you stop the negative energy balance and just ask the patient to stabilize his weight for a while, metabolic adaptation is going to reduce or even completely disappear. And so I think it may be a good strategy to incorporate some periods of weight stabilization in between the weight loss intervention and see if a weight stabilization is able to kick off the patient again towards a faster weight loss.
Yeah, that's really great. Our inclination is to turn the screws, right? To cause, restrict their food intake even more, to make them come in even more, to give them extra education. And all of that pressure may not be satisfying the problem, which is that their metabolism is resisting weight loss.
Yes, I would try, a period of weight stabilization and then try again.
Yeah, thank you.
Sure.
Do you have any questions from our students?
Okay. I was wondering, so could you comment on why you selected studies? You made a comment in the meta-analysis that you selected studies that did not only include exercise.
Yeah, so our question was how diet-induced weight loss impact on appetite. So therefore, we wanted the main weight loss to be driven by diet. So we included studies that had diet and exercise, but excluded studies that only had exercise.
So did including the exercise make the response different if it was combined with diet? Did you notice any difference, I guess, between the diet-only studies or the diet plus exercise studies?
I don't think we have done that analysis, but we know from previous research that when weight loss is induced by exercise alone, you have also a significant increase in ghrelin, driven by the weight loss, not driven by the exercise. And different studies show different outcomes when it comes to satiety hormones, again, depending on the hormonal fraction. So I'm not expecting big differences regarding appetite outcomes if weight loss is induced by diet versus exercise. However, if we talk about bariatric surgery, then it's a completely different thing.
Thank you.
Okay, so I guess we can call it a day if there are no more questions. Thank you very much, Dr. Martins.
My pleasure.
Honoring our invitation. You can give a clap.
Very nice.
Bye-bye. Thank you so much.
Bye.
Thank you.
And this will be, Dr. Martins, this will be up on our YouTube. I think that Ben had a link in one of the emails, so you'll be able to see it up if you want to share it with your lab.
Okay, thank you. If there are any other questions from anyone, either staff or students, just feel free to send me an email and I will try to answer the best I can.
Oh, that's fantastic.
Hey, Dr. Martins.
Thank you very much for, yes?
Would you mind one more quick question?
Yes, of course. No, I don't mind.
Okay. Literally just today, a study was published by Dr. Hall's group. It was a 2-week study looking at the plant-based high carb diet versus animal-based low carb diet. And they actually found that the plant-based seemed to reduce ad libitum feeding. Sorry, hard word. I was wondering if you had any ideas about that or could speculate that basically, this keto diet did not reduce energy intake as a lot of people seem to think.
Well, the impact of ketogenic diets on appetite is pretty well established. And my group has also done a lot of research in that field. So we know that when people lose weight with ketogenic diets, and if we measure appetite while they are ketotic, we do not see the increase in ghrelin or hunger that I have just shown you. So this is true. Now, when it comes to the impact of ketogenic diets on weight loss, then it's a completely different thing. And I think that the conclusion we have come so far is that really it doesn't make any difference. The main drivers of weight loss are compliance. So I think then we need to go to personal preferences and ask the patients, discuss with the patient, what do they prefer to try? Do they prefer to try a low carb, high protein ketogenic diet, or do they want to go to a plant-based, or do they want to go to a balanced diet? Because really the diet that they are better able to stick with is the one that is going to give the best results. That is what I would say.
Can I have a follow-up question, Dr. Martin?
Yes.
There is some data to suggest that weight cycling has a particularly detrimental effects on metabolic function. Any thoughts on potential mechanisms that might be contributing to these detrimental effects of weight cycling?
Well, I don't know if any recent evidence has been published, but my knowledge in this field is that there are no big, this is not a big issue. So the initial epidemiological studies that were done with weight cycling failed to distinguish between losing weight intentionally and losing weight unintentionally. So an individual that, for example, has cancer or it has severe heart failure, these individuals are going to lose weight unintentionally. And because studies that were done 3 decades ago did not separate these two, they tended to show that weight cycling was associated with an increased mortality. Now, more recent studies have only included intentionally weight cycling, and those studies do not show increased mortality. When it comes to the impact of weight cycling on body composition, resting metabolic rate, my understanding is that there is no significant effects, negative effects, but I have not read any new evidence. So if you have read a paper on the last 1 to 2 years, maybe there is something new that I have not read.
Okay, thank you, Dr. Martins. Very nice presentation.
Thank you.
Thank you. Bye.
Thank you so much. Bye.
Thank you.
Bye-bye, everyone.